Air Pollution Exposure Association to Early Pulmonary and Cardiovascular Disease, one study from Pakistan. China, there are many studies, I just quoted one, and then also the pure cohort which also established. So, I just want to end today with my thoughts or reflections. There are evidences now emerging even from LMICs to suggest that yes, air pollution is a major risk factor for CVDs. However, to really influence change and accelerate air pollution mitigations, what we need is that not just population-based evidence, but also we need to demonstrate perhaps that once we actually start implementing linear action plan, is there a health benefit in terms of the cardiovascular disease? So we need to really think about it, because I think that will be very, very powerful to convince further policymakers. Such kind of studies were done in US, but in India, I think intervention-oriented studies are quite less. And one of the reasons is that because this is purely interdisciplinary in nature, so we need to really strengthen also the interdisciplinary way. And between AIMS Delhi, which is a premier medical institute here, and IIT Delhi, from where I belong to, we started a CAFR India network program to mainly train early career researchers in methods of air pollution epidemiology, and I will leave these brochures in the registration desk. So we try to promote air pollution epidemiology research in the country, and there are similar programs also undertaken by PHFI and other groups. So yeah, just I will end here saying that evidence clearly suggests that CVD burden in LMICs, particularly India, cannot be reduced without meeting linear targets. Thank you.
Thank you very much for that really excellent presentation, Dr. Day. I would like to invite our next speaker, who is Dr. Akash Srivastava, who's going to talk about national initiatives for air pollution mitigation.
Good morning, everyone. I would like to thank the ACC ACF 2024 for putting together this plenary on air pollution and cardiovascular disease. It is indeed a serious public health problem today. I'll be speaking on the National Initiative for Air Pollution Mitigation and Adaptation. At the outset, I will acknowledge that there is a lot of work in air pollution being done by the non-governmental sector and civil society, but I'll be speaking and touching upon only some of the work that the government of India is doing in this regard. So we all know, unfortunately, most of India is living and breathing unhealthy air. And there's something that is important here to notice. There's two important points. One, that there is a trend towards more of urban air quality issues, and also it gets even worse at the time when we have colder temperatures in the country. As you can see in the slide out here, there is a more of urban population getting impacted in the rural, and in the AQI levels in the month of October to February, when cities like Delhi have a more severe problem. As coming to the impact of it, over the last 2 years, we have seen an estimated India of the attribution of deaths attributed to air pollution has increased from somewhat estimates of 1.2 to 1.6 million, now to 2.1 million deaths in 2021. And a lot of systems gets impacted, but the cardiovascular system is also being impacted, as you can see in the diaries and deaths attributed to air pollution by diagram. Coming to mitigation, a lot of ministries are working in mitigation, but it's spearheaded by the Ministry of Environment, the main ministry, collaborates and works together in mitigation. A lot of control, air pollution control initiatives have been done in the country by the government of India, but some of them will largely touching upon the climate issue. The first is the National Air Program. This is an initiative by the Ministry of Environment, and it has set a target that it will enhance the air quality by 2024 by 30%, and it has now extended its target to 2026 with 40% reduction in pollution level. Today, of 151 cities identified, 310 urban places have reduced substantially their environmental clean fuel, as you have heard in the previous presenter, that the household air pollution is a major problem in the rural area. Coming to adaptation on the program that exists in India, the program, a national program on climate change and human health, addresses many climate sensitive diseases, including air pollution. That is the three-tier system with the national level working from the Prime Minister's office, under Prime Minister's Council on Climate Change, the Ministry of Health, the Indian Rural Ministry, and the National Center for Disease Control and Support Ministry. And we also have similar structures along with the state, district, and sub-district level. The five major pillars that we address is the raising awareness in the population, building capacity of the health workforce, strengthening health sector preparedness, collaborative partnerships and research and development. The raising awareness is about putting in place advisory, IC campaign. Capacity building is about training and organizing knowledge workshops for our health workforce, be it the program officers, medical officers, or clinicians, or health workers. Also working towards inclusion of air pollution in health impact in both undergraduate and postgraduate studies of medical and allied disciplines. Instructing of health workforce means is putting in place a national health adaptation plan and state adaptation plan and district adaptation plan, and also putting in place a sentinel surveillance on air pollution related illnesses for the local policymakers to understand the impact of air pollution on the public health of the local population, and also disseminating AQI alert to health sectors and putting AQI monitoring in place in health facilities. Collaborative partnerships happen at ministerial level with different national programs, and also institutional level, and the research is driven by ICMR, Indian Council for Research. So this is the awareness content generation slide. On the right hand side, we see the advisory that the government has developed every year. In the month of September, the Secretary Government of India, Ministry of Health, will write with the Chief Secretary of State, now what are the actions that needs to be taken, assuming that the temperatures are going down and there would be a bad air quality days across the country. And then we organize our IVC campaign, Festival International Day of Clean Air for Blue Sky, that's falls in September, and on National Pollution Control Day in December, a week-long campaign across the country. This OPIC content in different languages that we put in the program. A lot of awareness activities of different types are also being organized under the program at different states. In capacity building, there are lots of manual and developed use of program officers, medical officers, and workers, or community level people who also put in place a compendium with the research of the Canada for our health professionals to have an understanding of what's going on. This is a slide that shows many physical and virtual training that are organized not only for the health care, but also for vulnerable population groups such as the tropical region. So in health sector preparedness, on the green manual that you see on the right side is the National Health Adaptation Plan of the country on diseases due to air pollution, which was launched by the Honorable Union Minister in 2021. Now all states also have a state-level action plan on climate change, which have a specific chapter on air pollution and health, and we are now in the process of developing a district-level action plan, which will also address the air pollution-related action. We also put in place a central surveillance for air pollution-related illness in the country. As of now, only collects information on respiratory emergency, reproductive forest adult emergency from central hospital identified in the country. As on date, we have almost 202 hospitals reporting across 178 districts in 30 states, but in future we plan to also add information about cardiovascular outcomes. This is a dashboard that you can see. It's an electronic digital system of surveillance that collects information on a daily basis across India. And on the right side, we have an alert system. As and when we have an half-year climate forecast, this alert system is activated and information goes out right from the health facility to the district level offices for the individual. This is a glimpse of what the data that we collected in surveillance in our program that just about information from Delhi clearly show that there is a relationship in the rise of the acute respiratory emergency cases, which are coming to Sentinel Hospital whenever there is a rise of air quality index, with a lag starting from day 0 to day 6. And that's not only for it is way down in the south of India, it is Chennai, but when we say Tamil Nadu, there is also an impact of how the cases are impacted with the rise of APY in Chennai, and both for APY level and for APY. So in the end, I would like to say that while India is definitely the first towards mitigating air pollution through initiatives of the Ministry of Environment and other ministries, and also adapting efforts that we are the national program of climate change and other initiatives. A lot of work is also being done by state governments and being done by other sectors which are non-governmental sectors in civil society, but we have a long way to move forward. We also look forward, importantly, to cardiologists and other clinicians because it's an important public health problem and can play an important role by putting them through awareness generation in the population that we interact, telling them about their vulnerability in this air pollution in the cities that they live, and also building capacities of the health workforce and how air pollution impacts the health of the people. In the surveillance also we will be very soon will try to put cardiology outcomes also in the surveillance system, and we can contribute by participating your hospitals in the surveillance system. Thank you.
Thank you, Dr. Srivastava, for your beautiful presentation. Now I call on Professor Debabrata to present his presentation on global air pollution policies. He's a very dynamic cardiologist of the country, working on global climate policies across the globe, and really I welcome you to present your lecture.
Thank you, Dr. Das, for that very kind introduction. Good afternoon to everyone. I'm actually standing in for Dr. Debabrata, who was doing this talk, but unfortunately he couldn't travel to Delhi. So I'm going to deliver this talk with some minor changes that I've made. In May of this year, the World Heart pollution across the world, and there are a lot of findings that I think I recommend you to read in detail. I'm just going to present some of the key features of that particular report. It starts with the burden, then talks about some of the policies that can mitigate air pollution across the world, and so I'm going to briefly discuss some of these things. So I have no conflict of interest for this topic, other than receiving funds from NIH and various institutes of NIH, Indian Council of Medical Research, and others. The question is, why should you know about air pollution? Even if we ask people in this room as to what does air pollution cause, everybody will say respiratory diseases first. But when you look at this figure, and I can happily say here, because neurologists are not here, we include stroke into cardiovascular disease. So if you put stroke as cardiovascular disease, more than 60% of the deaths due to air pollution is because of cardiovascular disease, and some say it's close to 70%. And these are data in terms of global cardiovascular deaths attributable to air pollution. And you can see, time and again, people have been telling that it's emerging as one of the topmost causes of air pollution is one of the most topmost causes of cardiovascular deaths. In India, we had the latest figure, which was 2 million deaths. This was from our state-level disease burden study. It said 1.24 million deaths, with 60% from ambient air pollution and 40% from indoor air pollution. But the most important point to make is deaths do occur, but it's the premature deaths which is a problem. A large majority of air pollution-related deaths occur before the age of 70 years, and that's a problem because it impacts the economy. And we lose almost 1.7 years of our lives because of air pollution. So air pollution affects everyone. More than 95% of the world's population breathes so-called dirty air. There's no safe level for air pollution, and the ill health caused by air pollution poses huge economic burden, and air pollution is known to harm every organ of the body, and the cardiovascular effects of air pollution is especially strong. But what are the pollutants in the air? This has been alluded to, but we're talking mostly of particulate matter 2.5, which is ubiquitous, and it's a tiny particle, and I'll tell you how tiny it is, and it enters the bloodstream and causes a cascading effect on various organs. Of course, there are gases and heavy metals. Because of paucity of time, I'll not get into detail. Just to give you a contrast, look at the size of the red blood cell here. This is the RBC, and look at PM2.5. It's very tiny, and it can cross the alveolar blood barrier and enter the blood. And once it enters the blood, PM2.5 can cause endothelial damage of the arteries, resulting in stiffness, resulting in hypertension and atherosclerosis. It can directly damage the myocardial cells, resulting in arrhythmias and heart failure, and it can result in inflammation by getting deposited in the fat cells around the abdomen, thereby causing endocrine disruption and also leading to insulin resistance, diabetes, obesity, among others. When we look at trends in particulate matter across the world, the Southeast Asian region, where India resides, has the highest proportion of particulate matter levels as compared to Europe and America, which you can see is pretty low, but it's still not reached the WHO standard of an average of less than 5 microgram per cubic meter of PM2.5. That is the recommendation. And the national standards for India is 40. So you can see how even our national standard is 8 times higher and we are not reaching that. In terms of air pollution and mortality, Southeast Asia again is number 2 in the world. It's very lower than the Eastern Mediterranean region. But the number of deaths because of the population size is the highest in Africa and in Southeast Asia. If you compare mortalities from ischemic heart disease and stroke combined, again Southeast Asia is higher. And in terms of stroke, because Africa has a high proportion of stroke, and Southeast Asia region has more coronary artery disease, stroke levels are little lower. And similar is the case with dialysis. This is a little busy slide, but the idea here is to show that there are various components of the air pollution apart from PM2.5, nitric oxide, sulfur dioxide, ozone, and several others. And each one of those causes different problems in terms of cardiovascular disease, in terms of heart failure, in terms of ischemic heart disease. So there are different components, and that requires exploration, which has not been done so far. Moving on, talking about indoor air pollution worldwide, 3.2 million deaths occur because of indoor air pollution. And indoor air quality refers to the air quality within and around buildings and structures, especially as it relates to the health and comfort of the building occupants. And there are various sources of indoor air pollution. The main sources include secondhand smoke, cooking with solid fuel, which is the biggest problem worldwide, heating with wood, building materials, and household products. So in terms of indoor air pollution and ischemic heart disease, India is not that high. The African region is very high in terms of indoor air pollution. I think from Karam Ujjwala scheme where clean fuel was used for cooking is reduced, but that needs a detailed evaluation. I think Dr. Srivastava can talk about it during the panel discussion. When you look at it in terms of high income versus middle income and low income countries have the highest proportion of indoor air pollution. So there are several interactions in terms of air pollution. We have seen climate change, the disastrous consequences of climate change, even within this country, the floods that we have witnessed in the last few months, and the hottest summer ever in the last May. So you can see the various things that get interacted with air pollution that includes climate change. We haven't spoken about other environmental pollutants that includes noise, light, water, soil, and pollution, smoking, biological interactions, various diseases. Urban design is an important component of physical activity, and there are also mitigation, which actually has some different kinds of interplay. But one thing the report missed is the gender issue in terms of air pollution. This is a case study of a husband and wife residing in Delhi. The husband is an auto rickshaw driver or a e-rickshaw driver, goes around the city. The woman is a homemaker and she's at home all the time. So we did a 24-hour monitoring of air pollution and looked at the difference between the husband and wife. And you can see here the color of the sensor, which is dark, and this is the color of what the husband had. And you can see it's 254. So there's a huge differential within a single molecule. And we need to focus on the gender in terms of air pollution. So the guidelines, policies, and successes have been mentioned in the report, and it says that less than 10 countries meet the 2021 WHO guidelines of PM2.5, which is average of 5 microgram per cubic meter every year, and on a single day it should not exceed 50. Less than 64 countries have legally empowered policies containing everyday quality standards, and majority of African countries do not have the empowered policies. But there are quite a few successes where we can learn from, and these are city-level successes, such as in Barcelona, Ulaanbaatar in Mongolia, in Cameroon, in Buenos Aires, and in Beijing. Out of the 194 states in the European Union, 122 states have legislation policy guideline. Whatever they have, they do have, but many others do not have. But WHO evaluated 121 of these countries that have the legislation policy guideline. None had legal standards that align with the WHO guideline for annual PM2.5. So the recommendations are majorly 5. All countries must adopt new WHO air quality guidelines. Countries should commit and maintain a global fossil fuel non-proliferation treaty. Improvements in air pollution monitoring and modeling are required, especially in the low-income countries. Increased funding for air pollution research and technological innovation to improve air quality is needed, and further research into the cardiovascular effects of air pollution is required. I'm just showing you an example because India has this standard of 40 microgram per cubic meter average in a given year. So I'm looking at, these were data which was published in Lancet Planetary Health recently, where we looked at ambient air pollution and daily mortality in 10 cities of India. And using this integrated exposure response curve, we observed that nearly 7% of all daily deaths were attributed to PM 2.5 concentrations, higher than the WHO guidelines, but lower than the Indian guidelines. So we really require reframing our guidelines, and most countries need to do that. The second thing that we need to look at is cardiovascular disease, as somebody said, starts in the womb and ends in the womb. Because what happens during pregnancy, what happens during prenatal life has a bearing in future cardiovascular disease. So we need to look at the effects of air pollution. And what we have done is we have assembled 7 cohorts, starting from birth cohorts, pre-pregnancy cohorts to elderly cohorts, and we are looking at the effects of air pollution at each point in time. For example, we will look at air pollution effects on gestational diabetes, birth weight of the neonate, and then look at childhood insulin resistance, and in the elderly look at vascular dementia. And we are looking at various exposomes which Dr. Day spoke about. We're looking at the interaction, social demographic factors, lifestyle factors, and physiological risk factors. Finally, I wanted to say that knowing is not enough, and we must apply. And this is a quote from Mohan Gate, the German philosopher. So the most important thing which can remedy air pollution on policy level, that includes regulation and enforcement. We need work on energy transition, promoting and investing in renewable energy, encouraging energy efficiency in buildings, transportation and industry. We need policies on transport, urban planning, clean industrial practices, creating public health and awareness, which Dr. Srivastava talked about, international cooperation and research and innovation. And which of these proposed policies could specifically address cardiovascular disease? There are quite a few here, and I can leave the slides because of the paucity of time I'm not getting into the details. And I would like to thank all the members of this draft report, which was, not the draft report, the access report, which was released in May. And finally, I would say with regard to air pollution, we have a lot of work to do, but we need to have that willingness to do something about air pollution for the future generations as well as for us. Thank you very much.
Thank you very much for that really excellent presentation. So I think we're going to have some time to talk to our panelists here. I would like to first ask our President Vivek. We know clearly there's a strong association between air pollution and cardiovascular disease. It's clear that the Indian government is paying a lot of attention and effort to try to improve air quality. And it's clear that as cardiologists, we have a responsibility to advocate for this because of this clear association. So, as president of ACC, I think advocacy is very important for what we do in the United States. So how do you think we can translate what we do with our own efforts to advocate for policies and decisions that may help move the needle even further or even faster. So what do you think are opportunities as for the CSI and cardiologists here to try to help with improving some of these policies to make things move faster?
Well, first I'd like to congratulate CSI. This is my second time with this group, and last year they did a global summit on air pollution, which was incredible. And today just cements the concept that we have got to figure out how to work on this together. And you took the words right out of my mouth, is advocacy. I think as cardiologists, we always tend to concentrate on the medical condition of our patients, but I think we realize that it is a holistic approach to our patients that is most important. The mere fact that indoor air pollution, that was just a fascinating slide that showed that inequity in just where we are breathing air on a day in, day out basis. And I think the one thing that I've seen as I travel internationally, as you're right, Dr. Yang, is advocacy becomes so important, and we have got to work with our governments in order to get the policies in place that are needed to change things. Because if we don't start somewhere, we won't start anywhere. And I think that's probably the take-home message, because we already know that our South Asian individuals have a earlier and more complex presentation of cardiovascular disease from a multiplicity of factors. And so therefore, we sort of know what's in front of us. And I think it's imperative that we utilize the resources that we've got. And as president of ACC, I think this is something we're a little bit more privileged to have in the United States with our clean air. We sometimes may take it for granted, which is a huge mistake, because I think this is a global problem that we all need to address. And I think the WHO requirements are something that we need to be behind and to make sure that we can effectively make changes across the world.
Thank you, Dr. Gupta. ACC can take up the leadership and ensure all the governors and all the members of different societies and to promote the health in terms of the air pollution. About that, and definitely ACC will take up the issue in a more respectful way. Now, let us know something about the inner aspects. Especially what the dirty air we are breathing and how that dirty air gets into our system and also cardiac or cardiovascular disease. I request Dr. Vivek Gupta to highlight how the particulate matter centers and ultimately causes heart disease and vascular disease.
I think it has been already discussed. So basically, the particulate matter 2.5 is they can enter the bloodstream. Not only the alveoli, they can enter the bloodstream and gets concentrated in different body organs. And the basic mechanisms of pathophysiology are three. One is inflammation, second is oxidation, and third is different metabolic changes that ultimately translates into endothelial dysfunction and actual damage to different tissues, and that can produce to heart failure, to arrhythmia, and coronary artery disease, and all. In fact, it can produce the entire spectrum of cardiovascular diseases in pulmonary hypertension.
That's very nice, and actually it was all the components of our body, the brain, nervous system, as well as the heart, the vessels, and inflammation is a very, very important thing which happens inside the body and all the cells. Now I request Dr. Vivek to tell us what are the different kinds of pollution, air pollution, which is known to many of us, but not to that deeper way that we should know. What are the various kinds of air pollution?
Actually, this is very intriguing, and air pollution is one of the most important reversible factor which can be actually reversed, but our somehow the system does not allow and it's not happening. You know the India, I was talking and I was listening to many talks. New Delhi is one of the worst affected as far as pollution is concerned. AQI, which is index which we measure every year and we have been following it. The question why, as Dr. Debabrata told us, that particulate matter is one of the most important, other than the gases, ozone and other things, which is leading to acute inflammation, leading to acute thrombosis, the plaque rupture. My question, my thought process, I mean, this is just a comment. I mean, we all know that sometimes acute exposure can also lead to acute coronary syndromes. How much acute, we don't know. Is it only 24 hours or few hours or few minutes? We don't know. Regarding the chronic effect, we are always doing that atherosclerosis is also accelerated by PM 2.5, which is one of the most important culprit for causing the cardiovascular disease. We all know that 7 million deaths all over the world is basically caused by air pollution. That means 70 lakhs people are dying. More than 60% of the deaths are attributed to air pollution in general. So the answer is not statins or ecosprin or aspirin taking. This answer is that we have to really find out the places, and unfortunately the system, the government, the NGOs, we ourselves are not able to take over this major crisis. Today it is a crisis, tomorrow it will be emergency. So I think we have to be very, very careful and talking to the government and other organizations. For example, in Delhi, you may not be aware that we have a rule that a 10 years old petrol car and 15 years old, a 10-year-old diesel car and 15-year-old petrol car will be abolished from the street. This is not there, nowhere in the whole world. This was one of the major action taken by the ministry government of India, that they will not be able to allow applying the cars which is older than 15 years for the petrol and 10 years for the diesel. Unfortunately, I don't think this has actually caused any reason, any impact upon this. So we all have to understand, we all know that CVD or cardiovascular disease and deaths are happening because of this particulate matter 2.5. What to do? Is it industrialization? We cannot stop. Is it management of this? We cannot stop. We have so many factors. Why New York is better than Delhi? We don't know. Why Paris is having less particulate matter 2.5 than other parts of the cities of India or Asia? We don't know. But we have to be very, very careful. And Dr. Debabrata and Dr. Mrinal Kanti Das, he has really pointed out. And keeping the session in American College of Cardiology is very, very important initiative. And I think all these minutes should also be passed on to the Ministry of Health. Whatever we talk here, it should be translated into some action. Otherwise, there is no point in doing such a seminar, just talking within the hall. It has to be action. And how WHO, how American College of Cardiology, how we can together, because it's the poor man who dies. We are not exposed to that much level. We are sitting inside air-conditioned environment. It's a poor population, middle class, the lower class, who are exposed to such particulate matters on the street. People are living on the street, going everywhere without mask. We cannot give the mask to everybody. So we have to really find an answer together. And I'm thankful to the ACC to give me a possibility to speak about this. And the things are not so rosy. We have to be very, very, very careful. Today it is 7 million, tomorrow it will be 8 million, 10 million deaths will be happening because of air pollution. And this is one of the reversible factors. That's most important. You can't reverse that. Many times it's genetics, which we always keep blaming, causing atherosclerosis, acute plaque rupture. So this is a reversible factor. We have to work hard on this. Thank you.
Thank you, Dr. So we'd like to open up to questions from the audience if there's interest. I mean, I think this is an opportunity for very stimulating discussion around this very important topic. Yes, ma'am.
Good afternoon. That was a really wonderful and a most useful, important topic discussed today. My comment is the tobacco industry is the single important preventable cause of cardiovascular death, not only in India, all over. So tobacco is not only suicidal, it is homicidal and genocidal. The person who smokes, he commits suicide because his lifespan comes down considerably. It is homicidal because people around him, including his wife and the child to be born, will be affected. Baltimore study has shown that women smoking or having the passive smoking, the child to be born will have the right-sided heart disease. And the third, it is genocidal because 1 ton of tobacco to cure, they have to fell 112 trees. And today, all over the world, whether it is the pollution as well as the global warming, tobacco industry is the most heinous one which is causing harm to the humanity. And I think the ACC and CSI, even if you take a small step towards banning the tobacco, it will be like a giant jump towards the humanity. I appeal to all of you to see that something is done to prevent. And this I have done myself as a president of our Karnataka chapter. We got the picture of cancer printed on the cigarette packet, and the smoking came down by more than 50 to 60%. So that's the reason that world that tobacco is the single important preventable cause of cardiac death in our country and all over the globe. Thank you.
Thank you for that very important comment. So I think there is no doubt that tobacco use is the most common cause of preventable death. And there have been efforts, right? So in the United States, at least the age for tobacco purchasing increased to 21. A lot of that is really, I think, the efforts of advocacy for the American College of Cardiology, the American Department, all medical societies in the United States strongly advocate for promoting that. So I agree 100%. I know, Kathy, you have some additional comments.
Well, I couldn't agree with you more, and again, it's something from an advocacy perspective that's critical. I also think the key with cigarette smoking, along with many other preventable elements, including healthy diets, should start with our children. And the more that we get that education in the schools, the better off it will be. And as Dr. Moon said, not only have we limited the age of smoking, we increase the taxes. You know, whenever you have anything cost more, you tend to start to reduce the utilization of it. I don't think we can underestimate the importance of educating our children. High blood pressure, diabetes, obesity, smoking. Those are all things that the kids will take home to mom and dad, and it's something that I think we should look at seriously.
Yeah, I think, Madam, you have made a very important point. Madam, if you consider India, the total tobacco industry, the conventional cigarettes represent only 25%, of which we get the data. We have the data, genuine data. The rest 75% is composed of indigenous cigarettes, what we call BDs. And we are, we hardly have any genuine data on that, how it is increasing. As per the global tobacco survey, we know that, of course, in India, the smoking has come down, and this is related to awareness. Now, if you call at a blanket banning of the entire tobacco industry, it will involve livelihood of millions and millions of people across India, and maybe in a broader perspective, if consider across the entire South Asia. So, I don't think that any government will be really willing to give a vote for a blanket ban. The other that we can really do, and which is in our hand, is to create and increase awareness. There are several studies that have shown that there is a distinct mismatch between awareness and compliance to stick to good lifestyle modifications. So this is a very important thing. And another important, I think, as Madam has told, that we need to teach our children. And there are enough studies which have shown that school children-based community awareness programs, they result is good. And in fact, CSI, on behalf of CSI, we have started a program involving 225 schools, and in association with the prevention section of ACC headed by Professor Young, and this is supported by the ACC chapter section grant, the first grant that is, I think, that has been granted outside USA. And we are trying to create on a regular basis a single cross-sectional intervention. There has to be a continuous, it should be a continuous process
and there should be some degree of positive reinforcement integrated in the program so that, and actually why we did that, because we have experience that such programs has led to healthy hygienic toilet implementation in the villages much before the Swachh Bharat program.
Yes, thank you, Dr. Lloyd. I just want to promote the fact that this is an opportunity where CSI and the ACC have joined together to work on this process or project around in children in looking at
So when we talk about this air pollution, noise pollution is also an important component. You see how much noise is produced near the aircrafts, busy road traffics, and that is really a health problem. And that should also be included in the air pollution. And that can be easily combated by the government initiative and other organizations. So we can use it is really reversible. We can combat it.
Yeah, thank you for that comment. We have two more questions.
Hi, Sandeep Nathan, University of Chicago. First of all, I want to thank and congratulate ACC and CSI for championing this cause. This has really been a fascinating discussion and about things that I know nothing about, but I should know a lot more about. I have a question for the speakers. About a year ago, I read a report about a prototypic tower here in Delhi called Berto, which is an air purification tower. And there's another prototype, I think in either Finland or Iceland, that literally removes pollutants, particulate matter from the air and compresses it essentially into a cube. Is that moving forward? Is that scalable? Is that part of the solution?
Professor Shabnik, please answer this.
Short answer is not scalable. It's not cost effective in a sense because the studies have clearly shown like it purifies within a radius of I would say 100 meters or so. So unless people are really close to that, they are not breathing clean air. So you need, I think there are theoretical calculations that for a city like Delhi, perhaps you need tens of thousands of such things. And the other important point is that the towers are also driven by electricity, which is coming mainly from coal. So overall, I think in the scheme of things, that's not cost effective. Thank you.
Just to add one thing, that there are some watches being developed for finding out how much PM 2.5 is actually being accumulated in this. And maybe some speakers may put a highlight, because there are some watches which are being developed and that will be very useful.
To say these populist measures like having these big towers are not going to be helpful. But actually I came to make the point what Dr. Vijayalakshmi was saying about tobacco. I completely agree with you that the governments will not banish tobacco, but there are alternate cropping patterns which are being experimented, and they are actually more water saving as compared to tobacco. So one should look at alternate cropping patterns and alternate employment patterns. In terms of I just wanted to say in terms of behavior change communication, we talk about awareness. Awareness is just one component of behavior change communication. So if you are targeting one single individual, the person should say three things: I know, I want, and I can. Your awareness targets I know component, but people don't do the I can and I want. So you need to empower people, you need to give them the wherewithal in terms of how they can handle. So you need to create an enabling environment, be it children or be it adults. And for that, we require a multidisciplinary group like here. One, we need an energetic profession. That's one part of the need. We need an enlightened quality like Dr. Srivastava here. We need an empowered community, and we need an enabling environment. So with an enabling environment, we will do a lot. Thank you.
Thank you.
Yeah. Good afternoon, everybody. This is Dr. Asha Murthy from Chennai. Wonderful talk from all the speakers. I just wanted to add a point that in relation to smoking, the well being said that fire at one end and fool at other end is very well good goes saying. Especially in relation to the women population, I have seen that there is an increase in the level of smoking in the recent time, in the last decade, in the youngsters. And that is the reason there is a higher incidence of going of premature child, congenital defects, and history of preeclampsia and other associated, all risk factors are increasing in the level. And number two is increase in the infertility. Because the level of smoking is increasing, the awareness has to be brought to this notice. Number two is, what about the women population with the heart failure with the preserved ejection fraction, because the microcirculation is affected in this situation and they go for higher incidence of HFpEF, especially with the women with the obesity.
Every other panelists and including the speakers, and they have done excellent job. The lighting ceremony was started to enlighten us. Actually, that is the good point of the lighting ceremony, that we must be enlightened. That is the point which has been put across all of us, that we should be enlightened, we should be aware, we should do the action regarding the pollution, not only air pollution, noise pollution, water pollution, and all the pollutions. And as the knowledge goes up and all the participations take place from all the departments, all the departments, then on we can reduce the global problem of cardiovascular disease. With this comment, I conclude the session.
Cardiovascular health and air pollution.